Maybe we'll go ahead and get started with just one or two instructions or housekeeping notes. Again, my name is Dr. Nancy Muller. I'm the Executive Director of the National Association for Continence, and I welcome you to this evening's educational webinar for consumers on overactive bladder. I hope that you have on your computer monitor the slide set and you're not having any difficulties there. You should have to the right of the slide set a small panel that where you can click on the word question, and if you have a question that you wish to ask, and just type your question in the bar and then click send or click enter, and it will come to us, and we're going to accumulate your questions as I go through the slides, and we'll get to all that we can as time permits at the conclusion of the slides. Any that we don't get to, we will still answer, and we'll post them on our website by the end of the week. So tonight is the first evening of Bladder Health Awareness Week, and we welcome you. So thanks very much for joining us. So first of all, what is overactive bladder? Well, overactive bladder is suddenly needing to get to the toilet to empty your bladder. It's certainly a preoccupation for being able to find the toilet and get to the toilet quickly. And in fact, about 10 years ago, the term toilet mapping was actually coined as a new phrase to symbolize the preoccupation that people with overactive bladder have. It definitely interrupts life and gets in the way of quality of life because you're constantly having to stop what you're doing and get to the toilet. The formal medical definition that has been developed by the International Continence Society is that it represents urinary urgency with little or no warning, and it may or may not be accompanied by urge incontinence. In other words, urgency itself, that sudden need without warning to get to the toilet and empty the bladder, is a sufficient symptom to represent overactive bladder. But it's also usually accompanied by frequency of urination, having to go to the bathroom more than 8 times a day over a 24-hour period. Anything greater than 8 times would be considered abnormal. And it may be accompanied by nocturia or needing to get up more than once a night to empty your bladder. And we'll talk about nocturia specifically in a few slides. It's important to understand and distinguish overactive bladder as a separate condition from stress urinary incontinence. And the reason why it's important to understand the difference is because they have different causal factors, and therefore there are different ways of treating them. But when you go to your doctor to describe your symptoms, it's important that you describe accurately what's going on with you so that you can be appropriately diagnosed and go down the right pathway of treatment. So what is stress urinary incontinence? Well, that really is represented by leaking urine when there's pressure placed, downward pressure on the bladder. And it's worse when the bladder is filling or full, obviously. So if you cough or laugh or sneeze or lift a heavy object, that creates pressure on the bladder. And if in the face of weak pelvic floor muscles that are there to support the urethra and the sphincter at the bladder neck, it's easy for urine to be pushed out or leak. And and it's more likely to affect women than men, and that's because the pelvic floor muscles are oftentimes weakened and even torn during pregnancy and childbirth. Well, how many people are affected by overactive bladder? It does, over one's lifetime, affect women as well as men. 17% of all women, 16% of all men, according to studies by clinicians across the country, and that translates into over 33 million adult Americans. It's interesting that men are more likely than women to experience urgency, but not necessarily that urge incontinence, and that comes back to the weakened pelvic floor muscles too. And women, on the other hand, are more likely to experience mixed urinary incontinence, or in other words, urge urinary incontinence, as well as stress urinary incontinence, especially after menopause. Another aspect of overactive bladder is to appreciate the different causal factors that are behind those sudden urges or those spasms. In a normal person without overactive bladder, the bladder wall is relaxed while it's filling and stores urine that's been produced by the kidneys and sent to the bladder. During that time, the urethra is closed off by the sphincter muscles. Muscles of the pelvic floor actually, as I've said, help to keep the bladder outlet where the sphincter is closed during filling by supporting the urethra. That's how it normally should work. And when the bladder starts to get filled, it actually sends a signal to the brain, which in turn activates other signals that cause the pelvic floor as well as the muscles at the outlet of the bladder to relax and open up. And then a separate signal is sent to the bladder that tells it to contract and push urine out. That's how it's naturally supposed to work. In instances of neurological damage, such as from multiple sclerosis or a stroke or spinal cord injury or Parkinson's disease, a neurogenic bladder results. That mixes up the signals or even blocks the signals between the bladder and the brain. Other times, the bladder just simply malfunctions, and frankly, it isn't entirely understood why those signals are crossed. This is referred to as an idiopathic or unknown or non-neurogenic bladder because the causal factor of that spasm isn't known or understood in the same context of nerve damage like a neurogenic bladder. I mentioned nocturia earlier, and nocturia is a condition that causes us to have to get up during the night, and it obviously it disrupts our quality of sleep if we're being awakened multiple times to urinate, and that contributes to fatigue and even depression. Well, there are people that call us and say, I'm fine during the day, but not at night. I can't get any sleep. And in recent years, nocturia has actually been isolated as a separate condition altogether, believed to be caused by polyuria, or the excess production of urine. In other words, the production of at least 2.5 to 3 quarts of urine over a 24-hour period. And this is believed to be a result of changes in the pituitary gland that regulates hormone production. And of course, as we grow older, we're no longer producing growth hormones, and it's believed that the pituitary gland needs some regulation as we age, so to speak. Nocturia is certainly a condition that can be exacerbated by edema or swelling in the lower extremities. If you have a tendency to have swelling around your ankles or in your feet, especially if you're on your feet or sitting all day long. And that can also be a problem in older adults who suffer from poor circulation. Why is that a problem? Why does that lead to nocturia? Well, if you think about it, when they're lying down in bed ready to go to sleep, those fluids move up from the feet, up from the legs, and then all that fluid is being processed by the kidneys early in the night and fills up the bladder. There are actually multiple reasons for nocturia, and we'll talk about some of those other causes that can contribute to frequency of urination and urgency, but certainly culprits include caffeine and alcohol, even exposure to cold temperatures and high altitudes. And I really can't cover this subject adequately without discussing how the aging process itself contributes to bladder-associated problems. We're the first to say that just because you grow older, you don't automatically become incontinent. But at the same time, it is true that the aging process sets into motion certain risk factors that make you more vulnerable. There's no question that the bladder begins to lose some of its elasticity, just like a rubber band that's been stretched over and over and over. It loses its ability to fully contract and spring back, contract and fully push out that urine. Consequently, there's always or an increasing problem with retention, and that urine that remains in the bladder more than 50 cc's after urinating actually can send signals to the brain that the bladder needs emptying. So mild retention itself can contribute to the frequency and urgency of urination. Older people are more susceptible to urinary tract infections, particularly women. That's in part due to this problem of retention, but it's also due to the fact that urine with some stress incontinence can leak into that urethra, and in a woman that already has a much shorter urethra than a man does, there's vulnerability to microbes and bacteria getting into that urine and having a haven for multiplying and developing into a urinary tract infection. There's no such thing as functional incontinence, but it is true that your bladder can be perfectly healthy, and your brain and the signals from your brain can be functioning properly. But if you have functional limitations that prevent you from reaching the toilet in time, then you can have an accident. And so we also address areas such as ambulation and safe ambulation, because we don't want people falling and getting hurt as they're trying to get to the toilet, even if there's absolutely nothing wrong with their lower urinary tract. Well, what does this mean? This means that if functional limitations are preventing you from reaching the toilet in time and causing you to have an accident because of arthritis or an abnormal gait, or as you get older you don't have the same sense of balance, or maybe you even have some peripheral neuropathy in one or both feet. Are there other factors that can impede your safe ambulation? You need to be assessed by an OT or a PT and get to work on things such as stretching exercises and other means to improve that gait, regain that balance, and address anything, including chronic pain and joint pain from arthritis that's getting in the way of getting to the toilet safely when you need to. Okay, so I've covered the definition of overactive bladder, what it represents, how it manifests itself, who's affected, how you're affected, the causal factors, how many people are affected. You obviously want to know what can you do about it. Well, I've divided the remedies into steps. And the first step is to make an appointment to talk to your doctor. And your primary care doctor or nurse practitioner or physician's assistant can rule out obvious causal factors such as pregnancy. A lot of times in the first trimester of pregnancy, women feel frequency of urination and can even sense urgency as things are changing in their pelvis. Diabetes, one of the early warning signs of type 2 diabetes can be frequency of urination. And also urinary tract infection. This is a symbol of urinary tract infection. Urinary tract infection, if it's accompanied by fever or pain upon urination or lower back pain, those are other symptoms, that can be treated with an antibiotic. If it's asymptomatic, it's typically not treated. But you shouldn't worry about having a urinary tract infection that's somehow going to be masked by any medication you go on for overactive bladder, because the medications that are developed for overactive bladder and on the market for OAB really are not effective in addressing a urinary tract infection. So you're still going to have that urgency, frequency, and the burning and pain upon urination and other symptoms. And frankly, the same is true with diabetes. Diabetes can be diagnosed with simple urine or blood test, but that's all. Diabetes are also unresponsive to the anticholinergic medications that are prescribed for OAB. So you've made your appointment, you've talked to your doctor about your symptoms and readily ruled out any obvious other diagnoses that would not be represented by overactive bladder, but may initially be confused because of similarity of symptoms. The second step is to get educated. And, of course, even prior to that first appointment, you need to be recording what's happening to you so you can talk accurately to the doctor about how often you're going to the toilet, when you're having accidents, how much urine you're losing. That's really important to understand. But also it's important to talk in terms of how those symptoms are affecting you. What are you sacrificing? What are you giving up? And as part of the self-education process, it's important to be familiar with the terms so you'll understand what the doctor's telling you when you get a diagnosis. Well, what do those interventions from a therapeutic point of view consist of? Some people think that behavioral interventions are not treatment at all, but they actually represent the first line of intervention, and I'll cover those in greater detail in a minute. The second level of intervention consists of prescription drugs that have been approved by the FDA and are currently available in the U.S. And I'll cover a number of those. And then if behavioral and pharmaceutical strategies in combination with each other are not helping you, then there's more invasive procedures that you can undertake. Some are in-office procedures, and some are even implants, and I'll cover those as well today. The main thing to know here is that there are three different categories of interventions: behavioral, pharmaceutical, and then more invasive measures of various degrees. So what does step 3 consist of when it comes to seeking remedies? First of all, among behavioral interventions, there may be dietary changes you need to undertake, such as I mentioned earlier, eliminating caffeine, alcohol. Artificial sweeteners are also a known and proven bladder irritant and can even induce frequency of urination too. Fluid management is important, and what we mean by that is being adequately hydrated. A lot of people operate on the myth that if they just drink less, they won't be running to the toilet as often. Well, to some extent that's true, but if you're underhydrated or dehydrated, as the case may be, it actually concentrates your urine, and that highly acidic urine in and of itself can irritate the lining of the bladder and send you running to the toilet because it sets in motion spasms of the bladder. Pelvic floor muscle exercises are important and can be helpful, especially in controlling or managing those urges, because when you do a strong pelvic floor contraction, it cinches that sphincter muscle closed, sending a signal in turn to your bladder to say, hey, relax, you can resume filling. And if you're in the middle of a spasm, which is what that urge is represented by, the bladder does relax, and that sense of urgency goes away. It dissipates quickly, and you can safely walk to the toilet without having to run or risk falling. We have a whole routine for bladder retraining, and yes, you do have to retrain your bladder if you've gotten into the habit of running to the toilet, which compromises its ability to have holding capacity. And lastly, losing weight is an important first-line strategy if you are excessively overweight or obese. We have clinical evidence that when obese people lose just 10% of their excess body weight, it can not only help cut back the number of episodes that are represented by leakage or stress urinary incontinence. If they've been diagnosed with that, it can actually help reduce the number of urge incontinent episodes as well. As part of your strategies for intervention, consider taking prescription medication. Right now, there are actually 12 different prescription options available today in the U.S., and one which may become available over the counter as early as next year. Also in 2013, there's a new medication expected on the market for Nocturia. And there are different types of medications that are out there. There's standard. By standard, I mean you take your medication twice a day. And then there are extended release formulas where you take it only once a day. And the good thing about the extended release formulas of anticholinergic medications for overactive bladder is that they sort of smooth out the otherwise spikes that people get in dry mouth from those standard dosages. So the extended release formulas are more tolerable. And if you have trouble swallowing a pill or you have trouble with some of those side effects, and I'll talk about those in a minute, there are also transdermal patches and topical gel options of ways of administering oxybutynin, which is the active agent in some of these drugs. And the nice thing about transdermal delivery is that the medication essentially bypasses the gut or the gastrointestinal system. And so you actually can deliver a lower dosage of the active ingredient, and therefore you don't get such severe side effects. So it lessens that dry mouth and lessens the likelihood of constipation and other problems. The newest prescription drug on the market is Myrbetriq, and the interesting thing about it is that it has a whole different mode of action, if you will, in terms of how it works. The anticholinergic, or antimuscarinics as they're called, work on a receptor of nerves in the bladder muscle, and they reduce the ability of the detrusor to contract. But Myrbetriq works by relaxing the bladder smooth muscle during the storage phase, which actually has the effect of increasing bladder capacity. So the point of all this is that if one drug doesn't work for you because you don't like the side effects or you don't think it's quite doing the job, be open to trying at least one other before you just give up on pharmaceutical agents, because we all know that different drugs affect different people in different ways. The other important message here is that combination therapy or behavioral strategies in combination with medication is the route to go, not one or the other, because research demonstrates over and over that combining behavioral strategies such as those mentioned a moment ago with an OAB medication is more effective than either alone. Well, what are some of those side effects that you might get from prescription drugs? I mentioned dry mouth. I mentioned constipation. Women are already more susceptible to problems with constipation than men. But if constipation is something that troubles you, first of all, be sure you are getting a proper amount of hydration or liquid every day. The average that an adult needs in who's active and living in a temperate climate is 30 milliliters per kilo of body weight, and that works out to be about 1.5 quarts for a 110-pound woman. Another strategy is to avoid constipating foods like bananas and rice. Increase your high fiber content, particularly the insoluble fiber foods like green leafy vegetables and so forth. Exercise to keep your bowels moving. Exercise makes a significant difference in tackling constipation. And we've also got a special recipe on our website and then our printed materials of a special brand recipe that you can make ahead and keep in the refrigerator, and this helps too. The most important thing is to frame your expectations appropriately. You should expect the severity of urgency to lessen and the number of urgent episodes or frequency of urination to be noticeably lower. But you also may reach a new normal. You may be urinating 9 to 10 times a day instead of 14 to 15 times a day. And if that's the case, you've been successful. But if your symptoms are not responsive to combination therapy and they persist or grow worse, seek a specialist to reconsider your primary care physician's original diagnosis. It may be that you still need to rule out some very rare situations, but they may be behind some of those symptoms that you're experiencing that appear to be unabated or by the medication or even growing worse. And I hesitate sometimes to even bring these up because it sounds like I'm being an alarmist. And you might say, well, why don't you get all these possibilities ruled out before you even start down a path of treating overactive bladder? Well, there are two reasons. One is the incidence of ovarian cancer or bladder cancer is sufficiently low that you don't need to be undergoing all the tests for all the possible things that could happen to you when you first go to the doctor. just as we don't have brain scans to see if we have a tumor when we initially have a headache and reach for aspirin. And some of these tests are extensive and expensive. And there are also other symptoms that accompany these. Ovarian cancer, for example, is typically accompanied by feelings of bloating and fullness, tenderness in the pelvic area, lack of energy, and there's special blood tests for identifying a particular protein that helps with diagnosis, as well as tissue biopsy. Well, how do you go about finding an expert? Well, certainly you can ask your primary care physician for a referral, and that dialogue needs to happen right up front. But NAFC can certainly help you. You can come to our website. Right on the home page, we have a Find an Expert section, and you'll be able to read in some instances about all the different procedures that certain doctors are trained to undertake. You can even identify who the centers of excellence in continence care are across the nation that we've named so far. Before looking for an expert, it's also important that women in particular understand the difference between a urogynecologist and the training of urologists. By 2014, many of them, if not most of them, should have received a board certification or passed a board certification exam in female pelvic medicine and reconstructive surgery. This is particularly important if you suspect that you have mixed incontinence and or pelvic organ prolapse and may need surgery for those conditions, as well as the therapeutic intervention for your symptoms of overactive bladder. I mentioned earlier the more invasive measures or procedures beyond pharmaceutical intervention, and I want to touch on those briefly. Percutaneous tibial nerve stimulation involves the delivery of a mild electrical stimulation to the sacral nerve via the tibial nerve in the ankle. And there are studies that have shown that patients with both neurogenic as well as non-neurogenic overactive bladder have experienced a significant decrease in their symptoms of urgency and frequency from this treatment. It's an in-office procedure, and it starts with 12 sessions. There's also Botox, and those injections are delivered using a cystoscope that's inserted through the urethra into the bladder. And it's clear from studies so far that patients do experience improvement. Studies are ongoing as to the exact number and dosage level of injections and also the long-term effects of cumulative Botox treatments. But so far, the FDA has cleared use of Botox for neurogenic bladder, such as patients with multiple sclerosis or spinal cord injury. And then if your symptoms remain unresponsive, that's oftentimes referred to as intractable urge incontinence, or they become more severe, such as urgency becoming episodes of urge urinary incontinence, where you're actually losing urine before you get to the toilet. You should definitely discuss with your specialist. Sacral nerve stimulation. Medtronic is the manufacturer of InterStim, and it was approved back in 1997, and it's been implanted for since that time in over 85,000 individuals worldwide. And it's been shown successful in 4 to 5 patients with urge urinary incontinence, and successful in 2/3 of patients with just urgency and frequency. And there are two steps to InterStim. There's actually a test, which is great. That can be done right in the an outpatient kind of procedure, and it tests to see how responsive your bladder is to delivering this electrical stimulation. And if that looks like it's going to work, then a pacemaker-like device is actually permanently implanted just beneath the skin, and it's adjustable actually, and it's sort of like a programming device. It sends a radio signal through the skin. There's a device that sends a signal through the skin to the neurostimulator that's been implanted, and then about every 10 or 12 years that pacemaker-like device has to be replaced. It's actually the titanium battery that's replaced. Beyond that, invasive surgery is rarely used to treat overactive bladder or urge urinary incontinence. In rare instances, there's a bladder augmentation or enlargement of the bladder, but that's considered for very severe cases that are not responsive to anything that I've discussed. So in summary, you should really feel encouraged if you have symptoms of overactive bladder, because there are so many ways to intervene and address the symptoms, and on various levels and degrees of invasiveness. And I really encourage you to work your way through all of them. Stay in touch with your doctor, and if necessary, see a specialist depending on how severe your symptoms are and how they respond to behavioral and pharmacological intervention. Most of all, stay in touch with NAFC and remain watchful for continuing innovation, because there's a lot going on out there. So what's coming up the rest of this week? We have more webinars. We have a webinar on Wednesday on the enlarged prostate and the diagnosis of that and intervention strategies for treating it. That's going to be led by Dr. Tuktai from New York Presbyterian Hospital. And then on Thursday, Dr. Jill Rabin from Long Island Jewish is going to be leading a webinar on urinary tract infections. In addition, we have Twitter chats and on general women's health. We've got a fall prevention video featuring Dr. Elaine Markland. That's going to be posted on our YouTube channel. Bladder Health is the name of that channel. And then Friday, on Friday we're having our closing ceremonies to Bladder Health Awareness Week, and there are going to be several giveaways: apps for your smartphone, DVDs on managing or treating UTIs, and we're also giving away our signature bracelets. You do need to participate in the webinars in order to be in line for those drawings. I appreciate very much your attentiveness this evening, and we've got time to handle some questions. So let me see what's come in from some of you. Here's one question that came in: are Kegel exercises worthwhile? They are worthwhile if they're done correctly, if those pelvic floor muscles are properly identified. And many times people need help with biofeedback therapy or the help of a trained nurse specialist or physical therapist to help identify those muscles and do those exercises correctly. The other thing that I want to stress there is that doing Kegel exercises or pelvic floor muscle exercises should really be a lifelong passion of yours, not just for your bladder health and being able to manage those sudden urges or minimize the leakage from stress incontinence, but also for your sexual vitality. So these are not exercises that you do and quit. You need to continue to do them over the course of your lifetime to maintain muscle strength and integrity. And here's another one about asking about InterStim therapy help with multiple sclerosis patients and the percent success. There has been some limited success with InterStim therapy and MS patients. There oftentimes is a reluctance on the part of some doctors to recommend any sort of intervention such as a surgery or an implantable device, but there's really no contraindication to keep you from considering InterStim therapy because it's considered minimally invasive and it doesn't trigger, or at least there hasn't been any research that I'm aware of that suggests that the actual implantation of the InterStim device triggers a bad episode of the disease. So you should definitely discuss that option with your doctor. Can an overactive bladder affect a man's prostate? That's a very interesting question. I'm glad you raised it. In fact, I should have brought up enlarged prostate or BPH because that is actually a condition that can mimic the symptoms of overactive bladder. And in fact, it's difficult many times for a clinician or a urologist to distinguish between enlarged prostate and overactive bladder on the surface of things. Certainly, the prostate can be palpated, and an enlarged prostate can therefore be diagnosed. But many times, doctors find themselves actually treating both. They may prescribe a medication to help either reduce the size of the prostate or a medication that can relax the smooth muscle of the urethra, which helps with flow. That's how Flomax got its name. And they, in turn, can also prescribe a medication for overactive bladder. So it is possible to have both and to have both treated simultaneously. Here's another question about Parkinson's disease. And yes, Parkinson's disease can be associated with or a causal factor contributing to a neurogenic bladder. In general, it's my understanding that there are not a lot of problems with urinary incontinence per se because of Parkinson's disease. Frankly, one of the biggest problems that people living with Parkinson's disease encounter is the problem of safe toileting and safe ambulation. They may sort of almost freeze and as they're trying to get to the toilet, difficulty even moving one foot in front of another, or they lose their sense of balance, and they have more of an abnormal gait. They're very prone to falling. So safe toileting for the individual with Parkinson's is extremely important. And in fact, our booklet, Continence Care for People Living with Parkinson's Disease, has a whole chapter devoted to safe ambulation or safely reaching the toilet from a fall prevention perspective. And we worked very closely with the National Parkinson's Foundation in writing that booklet. Let's see. Here's another question. Oh, well, this one was also. Let's see. We've already tried that one. Here's a question. Another one about Kegel exercises. I have tried Kegel exercises without good results. Is there a better exercise to tighten all abdominal muscles, including the Kegels? Certainly your abdominal muscles are part of I'll call it the infrastructure that helps your pelvic floor support your pelvic organs, including the urethra, and that's why it's helpful to work with a trained physical therapist or nurse specialist who can not only help you identify all those muscles, but also guide you on your journey through different levels of muscle exercises, including those abdominal muscles, to make sure that they're strong and helping to support all of your pelvic organs and help your pelvic floor muscles do their job adequately. So all of that needs to be taken into consideration. And in fact, the app for the smartphone that we're giving away at the end of this week through a drawing, just a random drawing, does just that. It actually takes you through the different levels of pelvic floor muscle exercises, including abdominal muscle exercises. That's another question. What is the best way to get fluid that accumulates in the legs to move before bedtime? Well, you know what I tell people to do? I tell people to prop up their legs. Ideally, get in one of those lazy boy recliners and lean back and prop the legs. Ideally, your feet at the height of your heart or at the height of your chest, so that gravity can be on your side and help to drive some of that fluid up towards your kidneys, which are located in the region of your lower back, and that's the best way that I know to sort of drive, if you will, that fluid that's accumulated in the lower extremities throughout the day. Here's another question about vaginal atrophy and the difficulty that this lady is having doing pelvic floor muscle exercises. They're not responding to electrical stimulation. Here's where local estrogen can really make a difference. And in fact, there are clinicians that have found beneficial outcomes from local estrogen therapy in the case of overactive bladder in that postmenopausal woman. And it may be that is something to try. The question here was whether InterStim would be worth trying, but InterStim, the pacemaker implant that I was describing a moment ago, is not indicated for addressing vaginal atrophy at all.